Okay, good morning.
Morning.
Good morning. My name is Sue Fox, and today we are going to be, that's okay, I'll do it up here, talking about ESI and triage. But before we begin the actual presentation, I want to play a little game. We're going to do a little Kahoot game. I think I just asked if everybody could please download the Kahoot app, which I think everybody just did, right?
Yep.
And this is just to kind of see where you guys are, like where your knowledge is. Because I know a lot of you have been working on triaging and ESI with your preceptors, and some of you are already off orientation and you've been using it, so I want to see like where you are right now before we begin. All right, so I'm going to start our game. Has anybody played Kahoot before?
Yes.
Yes, right? It's fun.
I haven't.
You haven't? Oh my goodness, well, you're in for a treat. Okay. Okay, so the game pin, you have to enter the game pin on your app, 978940. And it's going to ask you to put in a name, and you should be able to see your name up on the screen. Okay, number one EDRN.
I was born.
Dorothy and Rover. Okay, very good. All righty. Okay, so it's going to be 6 questions. All right. Patient presents with an injured right ankle. His vital signs are within normal limits. What ESI level should he be? What do you think? Just take a guess.
Oh, I accidentally hit it.
That's okay. All right, so level 4 would have been the answer. Okay, so we're going to talk about that. We're going to talk about why it would be level 4. All right. Number 1 EDRN is in the lead. Okay, patient is complaining of shortness of breath, respirations are 48. Okay, his SpO2 is 80%. He's confused. What do you think is going on with this guy? Right, level 1. Very good. All right. Okay, patient presents with a lump on his back, no drainage or fever. His vital signs are within normal limits. What do you think his ESI level is? Okay, would have been 4, and we're going to talk about why. Okay? EDRN still in the lead. All right. Patient is complaining of not urinating for 10 hours. Mild distress, 5 out of 10. What do you think? 3. All right. Okay. Complaining of shoulder injury, it's deformed. He's got a lot of pain, 20 out of 10. He's in moderate distress. Okay, 2. Good. All right, 1 more. Okay, 11-month-old, brought in by parents with fever and ear pain. No distress, vitals are normal. Level 5. Okay, so now remember what you answered, because we're going to talk about why we answered those answers. All right, actually, Dorothy. Woo!
Yay.
Even though I accidentally clicked the wrong.
All right.
Rover, that's embarrassing.
Actually, I'm not going to do that. Let's shrink this down. Okay. Okay, so let's talk about triage and ESI. Okay? All right. Okay, so here's our learning objectives. We're going to correlate the different components of triage assessment with the appropriate ESI level. We're going to differentiate between the types of patients seen in the emergency department.
12:45.
We're going to synthesize the appropriate ESI level using the correct number of resources, and we're gonna specify the appropriate ESI level using assigned case studies. Okay? So what is triage? What do you think triage is? When you're using triage,
Prioritizing.
right, we're prioritizing what we think the patient needs, right? So we're actually doing this all the time and we don't realize it, okay? When the patient comes in, you're doing this before you even know you're doing it. You're looking at the patient, you're noticing what kind of distress they're in, what pain they're in. This is even, you can even be doing this prior to taking vital signs, okay? The word triage comes from the French word trier, that means to sift or select, all right? And in 1998, WERS and IDLE came up with this 5-tier system to try to help us standardize the process a little bit. All right, so how does triage work? Ideally, we want a nurse that has worked in the ED for at least a year to be our triage nurse, okay? And that's because as you grow in your role,
So
you're
that's not me, huh?
not yet. But it will be. It's going to be soon. And then you'll be in charge before you know it. We want somebody who is growing in their role, who, you know, has some experience with it, and you will see that every day you'll get better and better. It's the responsibility of the triage nurse to quickly assess or eyeball each patient, sick or not sick. So when I say not sick, do I mean they don't belong in the ER? No, right. I mean, are they to a point where they need immediate attention versus can they wait to be seen by the physician for a little while? And we're going to talk about that, and that all plays into the ESI levels also. Patients who are the most unstable or who have the immediate potential of becoming unstable need to be brought in immediately. So we kind of know that already, right? And some of these patients might include what kind? What do you think? Who do we bring in right away?
Stroke.
Strokes.
Chest pain.
Chest pains, right? How about traumas,
Breathing.
right? Difficulty breathing, bleeding. These things are all pretty obvious to us. We know they have to come in right away. Sometimes it's not as obvious as you may think. Sometimes they're tricky, you know? And then patients who can wait for treatment are not considered emergent or urgent, maybe minor lacerations, ortho injuries, ankle sprains. Those are the people that we send off to fast track. So, what kind of patients do we see? Now, for those of you who don't know me, which you really don't know me very well, I am a Golden Girls fanatic, so I had to work Golden Girls into this presentation, so bear with me. So we do see the Roses. Anybody watch Golden Girls? Familiar with these characters? Rose is the sweet, kind, cooperative patient. She doesn't complain. She doesn't give you a hard time. And then you have the Blanches, okay? The Blanches are the self-centered people. They're very high maintenance, a lot of drama, always calling you over to the bedside for something or another. Sometimes it has nothing to do with why they came in. They just like to be pampered. Then you have the Dorothys. They're going to question everything you do. They already went to WebMD, diagnosed themselves, and now they're telling you what's wrong with them, and they've got a list of demands that they come in with, okay? And then there's Sophia, and she's so sweet, she looks so cute, but she'll knock you out. She's 98 pounds, but they get so strong that they'll knock you in the face, scratch you, you know, or she wants to jump out of bed. They get forgetful, okay? And sometimes they're not compliant, right? Because they don't want us to tell them what to do. And then we have our pediatric rascals. So we always have to think about our child population in the ER, okay? Children are not many adults. I know you've all heard that about 1,000 times, right? So we have to remember that when we're assessing children and treating children, we have to think about those different parameters. And then we have the Aussies, okay? Anybody ever watch that show? The Osbournes?
Yeah.
Oh my God, I used to laugh so hard at him. He's too much. It's amazing that this man is still walking around, right?
It is.
And he's going, what's going on here? Who? What? Who? What? Because he's confused and he has no clue what's going on, right? And we get a lot of these patients for whatever reason. We get a lot of drug and alcohol, okay? And then we get the code grays. We get the psych patients. And this is Gary Busey. He reminds me of a psych patient. If you put that straitjacket on me, I'm going to pull your endocrine system out of your body. This is this kind of guy. Bless you. These are the people who need to be medicated, sometimes restrained, unfortunately, okay? And they take up a lot of our time. They're very draining. When you have a section of 5 or 6 patients, these are the patients who take up a lot of your time when you need to be dealing with the sick patients, but you're being taken away from that because you're dealing with these kind of patients. All right, so sick or not sick, that's what we're trying to determine. So in order to figure out sick or not sick, we do a across the room assessment, okay? That's the first thing you're gonna do. Before you even get close enough to the patient, you're watching them as they're coming in the ER and you're figuring out what's going on with them. So they have some visual cues, there's auditory cues, and there's olfactory cues, okay? So visual, you can see what their level of consciousness is, okay? And if you're talking to them and they're not answering you or they're not answering you appropriately, then you can realize that. If they look like they're in any kind of signs and symptoms of distress, respiratory, difficulty breathing, you can see that. Pain, okay? Sometimes they're not going to tell you they're in pain, but you can tell they're in pain. They're diaphoretic, they're pale, they're maybe hunched over. You can see something's going on there. Skin color and condition, if they're bleeding, that's an obvious sign, right? If they're bleeding a lot. Are they able to walk? What's their general behavior? A lot of times we ask the family, is this how they normally act, or is this different from their norm, right? Because we don't know, we don't live with these people, right? Are they able to speak? Can you hear them breathing? Sometimes you don't even need to put the stethoscope on them. You can hear them from across the room. There's wheezing going on, something's going on, right? What's the tone of their voice? How is their language? How are they interacting with other people? Are they agitated, right? Do they have any body fluids or odors? Alcohol, you can smell alcohol. You can smell poor hygiene. These are the things we're all looking for here. And this is going to give you a cue as to where they belong in your ER. So your primary assessment, okay, we learned this from the get-go in nursing school, right? Circulation, airway, breathing, disability, exposure to environment, right? So circulation, how do we assess a person's circulation? How do you do that, right? Easy. You look at their skin. You can feel for a pulse. You can do pap refill, right? Do they take their blood pressure? Bleeding, hemorrhage, right? We talked about pap refill. What's their cardiac rhythm, okay? What's the intervention? We might have to give CPR. This might be somebody who is, and we're going to talk about it, a level 1 who needs a CPR immediately, okay? They might need, I can't talk this morning, meds, defibrillation, cardioversion, okay? If they're bleeding, we want to control the hemorrhaging. We're always going to be putting IVs in everybody, right? We do that all day long. Depending on the person, you might need 2 large bore IVs, okay? And we want to treat those life-threatening conditions. All right, so airway and breathing. Again, how do we assess for these things? We want to make sure that they have a patent airway, right? If we hear them, they're struggling to breathe, they're not talking to us, maybe their airway is not patent. If their level of consciousness is down, obviously they can't protect their airway, they might have to be intubated, right? So what's the intervention? What do we want to do? Open their airway, right? Keep the neck midline, stabilize them, head tilt, chin lift. These are all things that we learn in BLS, right? And then for breathing, we want to assess their respirations. Everybody should be using their stethoscope on a patient. And I don't care if the doctor did it, you do it too, because sometimes the nurse hears something that the doctor missed. So everybody should be doing that. Breath sounds. Looking for the chest wall movement, okay, if there's a chest injury. I know that you guys don't see a lot of trauma, but it does happen. We get those walk-in traumas or those trauma codes that come in, so this might be times that we'll be looking for stuff like that. Looking for the position of the trachea. So what's the intervention? What do we want to give? Oxygen. Oxygen, right? Use your airway adjuncts. So you have your oral airway and your nasal airways, right? The doctor will intubate, put in an ET tube, okay? There's other kinds of tubes too, like combi tubes, those kind of things you might be seeing coming in from the medics, okay? The medics sometimes put those things in for us. We want to suction. We want to remove any foreign bodies, okay? And we want to treat those life-threatening conditions. All right. So disability means neurologic, okay? When you think of disability, think of neurologic disability. Okay, so somebody mentioned stroke before. So if they're having any kind of stroke-like symptoms, again, decreased level of consciousness, look at their pupils, okay? Assess the pupils, all right? What's their motor function, their sensory function? If you have somebody that has a cervical spine injury, you know, these people don't always come in a nice little bow on the backboard with the collar on. Sometimes they walk in and tell you they fell off a ladder 20 feet. So that's something that you're going to do right in triage. You're going to put that collar on them immediately. We don't take any chances. Even if they're saying, oh, no, I'm fine, look, no, put the collar on because, you know, you have a cervical fracture until proven otherwise. Until we send you to CAT scan, you have a cervical fracture. So we want to make sure that we're stabilizing that, okay? And then exposure to environment. So extreme cold or extreme heat. In the wintertime, you're going to see a lot of these people, especially the homeless population. They're laying outside on that sidewalk for a couple of days. Now they're hypothermic and they're coming in. In the summertime, we get people with the heat stroke, that kind of stuff, right? And we might have to give them some warming, you know, the bear hugger, right? Or the cooling blanket. Okay. Oh, am I going backwards? I'm going backwards. Okay. So there's a lot of mnemonics that can help you to remember what to assess. It's not like you have to know the mnemonics. If you're doing all the steps, you don't really need to, but some people really do well with mnemonics. They use these because it helps them to remember. So you have your PQRSTT, which is provocative and palliative. So this is when you're talking about pain, okay? What makes it worse? What makes it better? Somebody comes in with a pain level, oh, I have 20 over 10 pain. But you see these people, right? You can tell who has 20 over 10 pain and who thinks they have 20 over 10 pain. It's terrible. And as you get more and more into your role as an ER nurse, we do sometimes get jaded, so we want to kind of not go down that road. We want to remind ourselves that we have to believe everything the patient is telling us. But you know, I got 20 out of 10 pain and I'm eating Doritos and drinking my Mountain Dew. That's not always
Talking on the phone.
right. Talking on the phone, you know,
Laughing.
you can kind of tell, right, exactly. But you want to always ask them, you know, 0 to 10, 10's the worst pain you ever had. What number would you give it? What makes it better? What makes it worse? What's the quality? Okay, so is it stabbing? Is it crushing pain? Okay, how long has it been going on? Quantity? Where is it? Okay, the region, and does it radiate anywhere? Does it go anywhere? All right. How severe is it? We talked about that with 1 to 10. What time did it start? How long did it last? And what's the treatments that you've tried at home? A lot of people, you know, they don't do anything. They don't even try to take an Advil at home. They come here and then, oh God, I'm dying, you know? And then you have your old cart, which is same kind of premise, okay? The onset, the location, the duration, what characteristics, what aggravates it, what relieves it, and what kind of treatment did you do. So it's basically the same information being elicited from both. It's just your preference as to which one you'd like to use. And then you have sample. This is another one for your secondary assessment, okay? So signs and symptoms, allergies, okay, and what reactions they have. What medications are you taking at home? Again, we talk about this, past medical history, surgical history, last meal, last oral intake, and events leading to the injury. Going back to this for 1 second, you know, sometimes if you start with what's your past medical history or what's your past surgical history, they'll say nothing. I'm perfectly fine. Okay. What medications do you take at home? Oh, I take metoprolol, I take metformin, well, because they think I take a pill, it goes away, I don't have it. So sometimes I actually would even start with what medications are you on at home first, and then backtrack to, now what's you're taking metoprolol, what do you take that for? You know, backtrack, because these people really forget. Or they'll tell you, I take the little yellow pill, the little blue pill, the little green pill, and you're supposed to know, you know, what that means. Okay. Other information to consider. If it's a child, we want to know what their immunization history is. Or if you're an adult and you've gotten some kind of injury where you have like a puncture wound or you have a laceration, something to that effect, we want to know when's the last time you had a tetanus shot, okay? Who's your primary care doctor? We always want to get height and weight, always, especially the weight. It used to be, years ago, we didn't really do that. We only did it for if we knew somebody really needed a weight-based medication, and children always got weighed. But now, we want to kind of change that process and make sure that everybody's getting an accurate weight, okay? What was the date of your last menstrual period, if this is a female, okay? And how did you get here? Because sometimes people have to have procedures done, and if they drove themselves here, they can't drive themselves home. Like if you're going to get moderate sedation because you hurt your shoulder, I'm not going to let you get in the car and drive yourself home, right? I want to make sure that you have a ride. Okay. So for pediatrics, here's another cute little mnemonic. Chief complaint, immunizations, allergies, medications, past medical history, the parent's impression. So what does the mother say? Mother always knows best. Sometimes yes, sometimes not. Diet and symptoms associated with illness or injury. Okay. And then you have your other populations. We see so many different kinds of people in the ER, we don't even realize that we're seeing all these people, right? Geriatrics, all right? You kind of have to think differently about geriatric patients too. Same thing with peds. With geriatrics, they don't present the same way. So if somebody is having a heart attack and they're over 80, they may not come in with that crushing chest pain. They might wind up coming in with severe shortness of breath, okay? Because they don't feel, their pain sensory is not the same as a regular adult anymore. They're older now, right? Also, pregnant women, okay? We have to remember, pregnant women, we all run away from the pregnant women, right? We cannot wait for them to go to L&D. But if it's an injury or something that needs to be immediately addressed in the ER, we need to take care of that first. But we also have to remember there's a baby in there, so the baby needs to be monitored, okay? All right. Okay. Cultural background may influence the values, okay? So we have to remember some cultures don't like us to make eye contact. Some cultures don't like us to touch them. I come from an Italian background, if you can't already tell, so I'm hugging and kissing everybody. I'm a little over here. But some people don't like that. They don't want to be touched, okay? So we have to be mindful of that and be accepting of that, okay? Some people, depending on their culture too, they don't want to be treated for certain diseases. You know, they don't want blood transfusions. They don't want certain things. So we have to remember that, okay? Language barriers. That's why we have our styrofoam phones, I think we call them, for our translation. And you know, you can't depend on the family member to translate for the patient. You have to use your phone because sometimes the family member is not telling us the whole story. Sometimes things are getting missed in translation. We've had that happen before where, you know, oh, and we've also had it happen where, I believe it was with a deaf person. I've heard a story where they had a family member who signed, so we relied on that, and then they went home and they wrote a nasty letter and wanted us through the hospital because we never offered them the deaf talk. Because by law, we're required to offer them that. So we have to think about these things, okay? And then domestic violence screening, if appropriate, if you feel like this is a situation where there's an abuse, we need to do a domestic violence screening, okay? We have to ask them how much they smoke, okay, how much they drink, do they have any suicidal ideation, all right, vaccinations, okay. All right. All of that I just told you needs to be done in 5 minutes, okay? Keep that in mind. Sounds easier, yeah, I could say it, right, but it's easier said than done. But eventually you will be able to do this really quickly, although it seems like a lot of information now. It's going to come to you very easily, okay? Because, you know, what happens if we wait? This person could be declining and we're, you know, and there's going to be questions that we talked about that you're not going to ask right away. Sometimes you just have to go right to the nitty-gritty, okay? All right, so in order to make all of that happen in 5 minutes, make it standardized and make it easier, we use ESI, okay? ESI is a 5-level system, all right? It's an algorithm. 1 is the most urgent, okay? And 5 is the least urgent, all right? So we're going to see here. So let's see. These are the 4 questions you need to ask when you're trying to determine what number to give. Is this person dying? Is this a patient who could wait? How many resources does this patient need? And what are the patient's vital signs? So we're going to talk about resources also. Hold on, I'm just going to make sure I'm still recording here. Okay. My computer's doing something crazy. Okay, all right, very good. So we're going to talk about what resources are. When in doubt, if you don't know what level to put them at, if it's between two levels, always put them at the higher level. It's better to have them there than to put them at a lower level, okay? And not give them what they need or not have them use the appropriate resource. Okay, so level 1, if your patient is dying, they need an immediate life-saving intervention right now. So what would be an example of that? What do you think?
CPR.
CPR in progress.
Yeah.
Right. Or maybe intubation. Something like that. They need something right now or they're going to die. Level 2. Level 2 is high risk. This patient is in distress, okay? They have disorientation, new onset lethargy, confusion. They're in severe pain or distress. This patient is very close to becoming a 1, okay? This is right there at the doorstep of becoming a 1. So what do you think level 2 could be? How about your STEMIs and your chest pain? Right, because they're not quite a level 1 yet, but he's going in that direction, so we want to catch him before he gets there, right? Then we have level 3, all right? 40% of the patients we see in the ER are level 3. Level 3 is what I like to call process of elimination, okay? So you come in and you have belly pain, or, you know, you have maybe kidney stones. You have something going on. We don't know quite what it is, but we know we're going to have to run a lot of tests to figure out what it is. And then by process of elimination, we're going to figure out what's going on, okay?
Is that like your pneumonia?
Pneumonia. Could be.
It depends.
It depends. But yes, for a pneumonia, you probably would start out at a 3 because you know that you're going to need IV, they're going to get a chest x-ray, they're going to get antibiotics, that kind of stuff.
So these are the patients where they're showing symptoms, but you're not sure what it is.
You're not 100% sure what's going on, right? But we're going to talk about how the level 3 could become a level 2, okay? So keep that in mind. And then there's level 4. All right, level 4 is your typical fast track patient. They're fine, other than the fact that they might have one injury that requires one resource. So my example that I love for level 4 is ankle injury, right? You hurt yourself, you really only need an x-ray, right? Yeah. You're not going to get IVs, you're not going to get IV meds, you're just going to get an x-ray, we're going to say, okay, is it broken, is it not broken, we're going to throw an ACE wrap or something on there, and we're going to send you on your way. And then level 5, patient needs no resource. All right, so
I ran out of my painkiller.
Yeah.
That's true. You ran out of meds, you need a medication refill, right? Or in the Kahoot that we had, the little baby that had the ear pain and the fever, all that baby needed was PO meds. PO meds are not considered a resource, so that could be a level 5. The baby's in no distress, they're not dehydrated, they're drinking, they're, you know, talking and whatever. They just have some ear pain and a fever, it's a level 5. All right, so what's a resource and what's not a resource? You know, this is the age-old question, and a lot of this has to do with, really it comes down to what are we billing for and what are we not billing for. I mean, well, we still bill for it, but it's considered more when you bill for a resource. So resources are labs, x-rays, CAT scans, EKGs, IV fluids, IMs, injections and tetanus, nebs, nebulizers, right, for breathing treatments, specialty consults. So if you need a consult to a surgeon or you need a consult to a cardiologist, okay? Crutches, splints, slings, and complex procedures such as conscious sedation. Not a resource is a history and physical, POC, which is point of care testing. That's either your finger stick for glucose or your urine, okay? Just putting a saline lock in a patient is not considered a resource, okay? You have to actually give them something through those saline, or draw your labs and send labs off for that. PO meds, a call to their primary doctor is not a resource, and simple wound care is not a resource. Simple wound care would be just cleaning out a wound, putting a little bacitracin in, and covering it up. It does, if you have to do like an incision and drain and all that, then that's,
Like the family member who fell in the hospital.
right. Maybe they skinned their knee outside, right, and they need a little, a little boo-boo tending. Okay. So, we wanna perform an across-the-room visual assessment, right? We wanna make sure that we are figuring out what's going on with this patient the minute they come in, okay? Use the components of the primary survey: circulation, airway, breathing, disability, and exposure. Those are your primary, okay? If you identify the need for immediate care, greet the patient and the family. Don't forget about the family. We always do, right? Especially if something really bad is going on, level 1, level 2. The family, you have to kind of let them know, okay, we're doing everything we can. I mean, we'll get them a chair, we'll get them coffee, because, they're scared to death. Nobody ever comes to us on their best day, right? They come on the worst day possible. Review the patient's primary complaint and related signs and symptoms. Perform a targeted history. Review the patient's meds. Begin a secondary assessment. Okay. If it's a trauma, we want to know the mechanism of injury. That's very important. Sometimes EMS, the local squads, they forget that that's a very important thing to know. If somebody's in a rollover, I don't care if they were outside of the car 5 minutes later or walking around, they don't belong in a non-trauma hospital. They belong in a trauma center, because sometimes those injuries don't show up right away. And then all of a sudden the patient is decompensating, and what are they doing here? Now we've got to stabilize them and get them out of here, right? We want to perform a targeted physical assessment, obtain the patient's vital signs, perform a pain assessment, assign a shared triage rating, which we talk about with the ESI. We want to communicate that level to the ED team. So when you bring the patient in, don't just dump the patient off in a room and walk away. We want to let the primary nurse know, okay, I put so-and-so in room 5. Here's what's going on with him. We also want to swing by and let the doctor know quickly. Room 5 is, shortness of breath, or room 5 is whatever. Don't leave them behind the curtain, because if they're really busy, obviously they may not get there right away, right? Communicate, triage, okay, we talked about that. Obtain additional information as needed. Continue to monitor and triage patients who remain in the ED waiting area. Perform hand hygiene and document your triage assessment level and your care provider. Okay. Anybody have any questions on that? No? All right. We're going to do some, what am I time? We're going to do some quick case studies together. How about that? Oh, the fun, right? You're welcome. Okay. Everybody's got one, right? I need one. Oh. All right. All right. So, first one is a 56-year-old male. He comes to the ED triage area with complaints of chest pressure, nausea, and he's had this for 2 hours. He states that he has a history of increased cholesterol that he controls with his diet, so he's not taking any medications. Patient is on no home meds, states that he has not had a primary, he does not have a primary doctor. He smokes 1 pack of cigarettes a day, and he states that he has no allergies. And you can see his vital signs there. So based on what you just read, what level do you think this guy is? 2, right? And why did you determine 2?
Because he needs resources right away.
Right.
He needs more than 1, but he's not.
He's not a
It's a
1,
severe cardiac
but he has having chest pain, right? So we don't know, right? And he does need immediate attention, right? We determined that. Okay, so what's our next steps for him? We want to get him lined, labbed. We want to get an EKG, right? We might want to activate the cath lab, okay? All right. All right, very good. What about this one, number 2? Dorothy, you want to read number 2?
Sure.
Okay.
Miss J, an 82-year-old female, is brought to the ED by EMS. Patient is confused, and the EMTs tell you that her neighbor called 911 after she was unable to reach the patient for over 24 hours. According to her neighbor, Miss J is usually alert and oriented ×3 and lives alone. No other history is available, and you do not have a list of Miss J's current medications.
Okay, so you see her vital signs, right? And she has a pain score there. So what do we think?
It's still a 2.
Everybody thinks 2?
I'd say 3.
Okay, so
Yeah.
I would go with 2 only because she has an altered level of consciousness and her vital signs are abnormal. Right. So one of the things about level 2 versus level 3 is if you're at that point where you're like, okay, this is a 3. But then when you take their vital signs, you notice that they're outside of your normal limits, okay? So they have a very high blood pressure or very low blood pressure, they're bradycardic or they're tachycardic. That would automatically prompt you to bump them up to a 2, okay? So we want to go with 2. All right. So she needs immediate attention, okay? And what's our next steps? Everything, right? Romer, that's what you were thinking about with a 3, all these resources that we're going to use now. Because she's going to get a CAT scan, she's going to get blood work, she's going to get all these kind of things done. Because we don't. All right. Jean.
Lila, an 18-month-old female, is brought to the ED with her mother. Mom states that Lila has been crying on and off since last night and has been holding her left ear. Mom states that Lila felt warm last night but did not obtain a temperature. Mom states that Lila is on no medications and has no significant medical history. Lila was treated for an ear infection approximately 6 months ago with amoxicillin and developed hives 24 hours after the start of her treatment.
All right. So there's her vitals, okay? Her vitals are not bad for a 18-month-old baby, okay? And we're assessing her at a 2 at a flat scale, okay? She's sitting on her mother's lap, she's drinking juice, and she's crying on and off. So what do we think with this baby?
4. I'm between 3 and 4.
3.
Right, because, it's tricky. You could go with 5, because you could say, oh, well, she only might need PO meds. But then they might say, well, you know what? Maybe they look in her ears and they don't see an ear infection. Then you have a fever of unknown origin. Then the next thing you know, they're working this baby up. So it really would depend on whether after the assessment they found whether it really was an ear infection or not. If it's an ear infection, you maybe be able to go with a 5. If it's not an ear infection, then that's going to bump you up to maybe a 3 because they really need to, they would wind up doing a workup. And nothing worse than a workup on a baby, right? Nothing worse than when they want you to catheterize the baby. Oh, I can't stand it. That's like my worst. I'll take care of any adult any day of the week, but not really a pedi nurse. Okay, Romer.
Miss M, a 25-year-old female, is brought to the ED by her father. Dad states that he found his daughter lying on the bathroom floor with a laceration to her left wrist. Patient is holding pressure to her left wrist and is quiet and withdrawn. Dad states that his daughter has expressed that she no longer wants to live and that approximately 6 months ago she tried to jump out of a moving vehicle. When asked, Miss M denies any suicidal or homicidal ideation and states that she just doesn't feel like talking about it. Miss M has no significant medication history and is on no medication at home. Patient states that she has no known allergies.
All right, so what do you think about her? What is primarily going on with this patient?
She's bleeding. Psych.
She's psych. Right. I wouldn't even think that she's really bleeding much from that wrist. It's more of an attention-getting wound, but she is psych. But she's denying homicidal or suicidal, but the family is telling you these stories about her jumping out of a moving vehicle.
Mm-hmm.
So where do you think that we might want to put her on that scale? You think a 3? What do you
I'm
think?
thinking of 2.
You think a 2? What do you think, Romer?
Romer's
Stop
like,
asking me.
You get the wrong answer no matter what.
Right.
2.5.
Right.
I'd say a 3.
Okay. Actually, a suicidal is a 2. And it's only because they're so unpredictable, you don't know what's gonna happen, the risk, right? And whenever a patient comes in, even if they deny suicidal, homicidal ideation, we listen to the family
Right.
and we listen to the police. We take into account the whole story,
Situation.
right? Because, sometimes they're not gonna tell you the truth. So, right, absolutely. Okay, and our next steps with her would be first to treat the wound, okay? But she definitely needs to be cleared medically and she needs to have a psych consult. All right, so I'll read this one. Mr. R, 35-year-old male, presents to triage complaining of lower back pain and blood-tinged urine. Patient states that his symptoms started approximately 4 hours ago and that he took some Motrin but has had no relief. Patient rates his pain as a 10 out of 10 and states that his history of hypertension he has a history of hypertension. He takes Norvasc 5 milligrams PO daily. Patient is allergic to penicillin. He smokes a pack and a half of cigarettes a day. So here's his vitals. His pain is a 10 out of 10. His blood pressure is elevated. All right, what do you think he is?
Right.
2.
2. What did we say about the vitals, right? If the vitals are elevated, we're gonna bump him to a 2. Correct.
Kidney stone.
He's got a kidney
Yeah.
stone, right. That we could diagnose a
You can
mile
just
away.
tell from
right?
the picture,
Yeah,
that's what he's got.
yeah. Yeah, we have a little picture of the man with back pain here. Okay, and then, so you're gonna do the same kind of workup and stuff, but we would bump him up to a 2 based on his vital signs. All right, and he probably is a 10 out of 10, because those are painful. All right. Dorothy, you wanna read the next one?
Sure. Maggie, a 12-year-old female, is rushed to the ED by her parents. Maggie is in respiratory distress and is pale and diaphoretic. Maggie's mother states that Maggie is allergic to peanuts and may have ingested some unintentionally from some store-bought brownies. Maggie is unable to speak and starts grabbing at her throat. You notice that Maggie's face is red and becoming swollen and that her lips are becoming cyanotic. Maggie's parents state that she has no other medical history and is on no medications at home. Maggie's EpiPen has been missing for approximately 1 month.
All right, so what do we do?
One.
She's a 1, right? Because she is probably gonna need to be intubated, this poor child.
Respiratory, too fast to count.
Right, respiratory rate
Yeah,
is
she's
too
in
fast to
trouble.
count, exactly,
She's
she's
in
in
trouble.
big trouble, right, exactly. Okay, very good, and we're gonna have her intubated, and, we're gonna treat her for that allergic reaction, okay? All right, Jean?
Okay. Mr. S, a 20-year-old male, is brought to the ED by one of his teammates. Mr. S states that he was playing recreational baseball and was running to catch a pop fly when he heard a pop in his right knee, after which he fell to the ground. Patient denies hitting his head or any LOC. Mr. S has no significant medical history and takes no medications at home and states that he has no allergies.
All right, so what do you think this guy is? He's a,
Or
a 3 or a 4, right, depending on what he needs. He could be a 4 if he just needs an X-ray. But if he is a 3, actually, if he needs an X-ray, he needs crutches, he could be bumped up to a 3. So it depends on what's going on
he's
with
gonna
him.
need those things.
Right. And we gotta tell him that he can't play baseball anymore, which is really gonna be a problem.
Not in high
Or
school
he's
anymore,
not.
buddy.
Right, exactly. Okay, Romer, last one.
Mr. M, an 85-year-old male, is brought to the ED by his daughter. Mr. M's daughter states that she was eating breakfast with her dad approximately 45 minutes prior to arrival to the ED when she noticed that he began to slur his words. You notice that the patient seems confused and appears to have a right-sided facial droop. Mr. M has a history of hypertension and high cholesterol and takes metoprolol, 50 milligrams BID and Lipitor, 10 mg daily. Mr. M is allergic to sulfa drugs.
Okay, so what's happening to Mr. M?
Stroke.
He's having a stroke, and we're gonna put him 2.
Really?
2 until,
I want to be a 1 if I'm having a stroke.
you wanna be a 1?
I just
Okay,
want you to
we'll
know.
make you a 1.
Yeah.
Yeah, he technically is still a 2,
Okay.
unless he really starts to decompensate. Like say, for instance, he is having a brain bleed, and maybe we have to intubate him, we need to protect his airway, then he'll go to a 1. But if he's like a TPA candidate, he would be in a 2. Okay, you guys did awesome. Thank you for joining me.
That was
Anybody have any
fun.
questions? That was fun? Oh, I'm glad you thought that was fun.
Can we do more?
We'll give you
All right, I'm gonna
homework.
remember that you
Homework
said
for
that.
homework.
Right. All right, thank you so much.